Hi everybody and welcome back to week 4 of the Birth for Humankind Bicultural Doula Training Program. This week's session is mostly about meeting the birth team, so understanding all the various people that support your client during the pregnancy, but of course very much during labour and birth as well. So we'll explore the sort of various people involved in that support team. We will also explore the scope of practice for a doula. So when I say scope of practice, essentially what I'm talking about are the things that would be appropriate for a doula to do within her role as a doula, as well as things that really would not be deemed appropriate, that would really fall outside that scope of practice. And that's really important to understand. As I said, the things that we do and the things that we don't. So we'll look at that, and there are a couple of activities that you can do in Better Impact that will really kind of help to kind of understand very much what that scope of practice is for a doula. And then we will also sort of start to touch on what we often call the hormonal physiology of childbirth. And essentially that's really understanding what the role of hormones are, what they play in pregnancy, in labour and birth, and early postpartum. So what the hormones are, what they do. And then also later in the course, we will look more at what happens to hormonal physiology and that normal release of hormones and that sort of cocktail of hormones when somebody's labour is effectively interfered with through a process of something like induction or speeding up labour artificially through a process called augmenting. So, you know, at the moment though, we'll just sort of have a sort of high-level overview of what those hormones are. So let's get started. Right, so let's get started looking at the birth team and who's involved with that. So over the next few slides, we are going to be looking at the role of partners, doulas, that's you, midwives, doctors, as well as other support people. So the next slide, we're going to start off with the partner. So starting with the woman's partner, you know, in many cases that will be the father of the baby, but not always. Also, it's important to recognize that the partner may not always be a man. It may be somebody who identifies as male, but we do need to have quite a broad, I suppose, perspective on when we're talking about families in general. So I'm going to just, for the sake of convenience, refer to partner, but just at the back of your mind, recognize that that person may be different depending on your client. So in general, the role of a partner, so obviously we're not talking about a clinician, you're not talking about midwives and doctors, and we're not talking about doulas in this instance. Partners play a very, very important role during pregnancy, very much during labour and birth, and of course into, you know, the whole postpartum period as well. Ideally, partners do provide continuous support, but their presence may also be intermittent. And there could be a variety of reasons for that. Just to give you a couple of examples off the top of my head, if it's not the first baby in the family, then the partner or the father, whoever that might be, may actually need to be at home for, you know, at least periods of time caring for other children, and so they're simply not able to provide continuous support throughout labour. Hence why a doula might actually be really, really helpful there. In other instances, it may be that there is a religious restriction for the partner, often in this situation a male partner, from being in close physical proximity to his wife during labour. And again, so his presence may be continuous, but in terms of his actual hands-on ability to provide that physical support may be limited, depending perhaps on some religious sensitivities. The other thing as well is if that person is, you know, the partner of the birthing person, then they often do, you know, have legal rights as well. And so when it comes to sort of informing the family about developments during the labor, for example, or equally during pregnancy, they're involved in that situation. They're involved in decision making. They're also able to communicate directly with the woman's care team. Of course, there are instances where only the woman can give consent to specific interventions, medications, procedures, etc. And in which case, even if the partner is right there, the consent must be sought from the woman herself. It's only in those exceptionally rare circumstances where the woman is incapable of giving consent, due to her medical condition or being unconscious, for example, in which case her next of kin, who in this scenario might obviously be the partner, might be her husband, will have that legal capacity to give consent for an emergency procedure, for example. So yeah, as you can see, they do play a very, very important role. I think it's fair to say that in many, many situations, a lot of partners feel quite unprepared for what's required of them. They feel a little overwhelmed with, again, that role and the expectation of them to be a good support person. This is very much my opinion, but I think that in some cases, we put too much pressure on partners to kind of be the everything. We expect them to understand birth. We expect them to understand complications of birth. We expect them to provide unwavering emotional, physical, and informational support. And that's a very tall order. That's an awful lot to put on somebody who has little to no experience of birth, and of course, is unlikely to have physically gone through birth themselves, and so has even kind of less of an understanding on a sort of really innate level as to what their partner is going through. So in our next slide, we're going to be talking about doulas, and I think this is one of the really important things that doulas can provide, is that additional support for partners as well. So we'll talk more about that in just a second. So let's take a look at doulas now, which is all of you. Soon will be all of you. So there are lots and lots of definitions of what doulas do, but generally what a lot of people will agree on is a fairly broad definition of what doulas do, and that is that we provide continuous presence or support, for emotional and physical and also informational advice. So that's non-clinical advice. We're not giving medical advice, but we can certainly give information and resources. Again, depending on when we are meeting with clients, what we discuss in an antenatal appointment is obviously very different to the information that we're providing during labor and birth as well in a real life scenario. As you can see from the slide there, doulas also provide guidance for the partner or other family members who might be present at the birth as well. And that follows on from what I was just talking about in the previous slide about the role of partners, is that, there is a lot of pressure on them. We also can't forget the fact that they are also going through a deeply emotional experience themselves. Often people talk about birth being a very transformational experience, which is a great word to describe birth. It really does transform us, and it changes us kind of, irreversibly, really, as we transition from our roles, prior to having children to, becoming parents. So I think it's important to acknowledge partners as well. As doulas, primarily we are there to provide that physical support, as I said, and emotional support for the woman, for the birthing person. But certainly there are many, many instances, particularly when things may get complicated during the labor, when there are decisions to be made, which can absolutely affect the the labor going forward, the direction of that labor, and the various options that may be available to that person. And sometimes that information can be very overwhelming, particularly for the person who's in labor, but sometimes equally so for the partner. And so doulas can be a fantastic sounding board. They can also be a really great resource as far as being able to sort of simplify sometimes the information that has been presented to the woman and her partner by her clinical care provider, so the midwife or the doctor or both. And often, you know, to be honest, sometimes that those conversations do happen relatively in private, so between the couple and the doula, once information has been passed on by the medical care team. So doulas can be really, really good at just simplifying information, peeling back the layers a little bit, helping them to sort of see as well perhaps the consequences of certain actions. So if the hospital has suggested doing A, then the doula can sort of then say, well, you know, yes, if we do A, it's important to remember that it has, you know, this effect or this knock-on effect, or this will be impacted and so forth. And that might not be, you know, the full information and conversation that the woman is getting from her medical care provider. So that's different to giving clinical advice. That's something that we have to be very, very careful not to do, or as I said earlier, not even to be perceived to be doing, even if that's not our intention. We're not there at all to replace or override her clinicians. So you know, those are sort of, I would say, the sort of the main things that really are doulas do in terms of their advice. Another thing as well, I think that doulas can be extremely helpful for is that, you know, on the one hand, I think we do have the ability to fill the gap that currently exists in the maternity care system, where most women do not receive what we would call continuity of care. This is when a woman is cared for throughout her pregnancy and labor and birth, essentially by the same person or the same small team of people, like a group practice, midwifery group practice, for example, model. Most women we know receive what we usually call stranger care. So they see a different woman at every antenatal appointment, and then they have no idea who's going to care for them when they arrive at the hospital in labor. So when a woman hires a doula at whatever stage during her pregnancy, hopefully relatively early on, she has that time to build a relationship of trust and familiarity, and certainly one where the woman feels that, you know, her needs are being met in terms of that, so that emotional support, that continuity of support, knowing as well that peace of mind that doula will be there at the birth. Some doulas are also adopting a kind of a team doula approach, not so dissimilar to midwifery group practice, so that the client from the outset will say, you know, look, I'm the primary doula. There's a really good chance I'll be at the birth, but sometimes, you know, I may be at another birth. I might be unwell. There may be some reason that I can't attend the birth. And so, you know, this is the other doula. And so if it's not me, it'll be this doula. Sometimes they get called backup doulas, but actually what I'm talking about more is a team doula approach. And these are things that we can talk about certainly more in the course as we go forward. Excuse me. So doulas, I think, do have this incredible opportunity to provide that continuity of care that, as I said, is so lacking in our current maternity care system. And so when a woman is in labor, just that the peace of mind, you know, knowing that there's that familiar face in the room, that calming presence, that person that she has built trust in, you know, in the months leading up to the birth. But at the same time, she's not her partner, she's not her mum, she's not her sister, and she's not her medical care provider. So there's a different relationship that she has with her. It's familiar. And as I said, it's calming, and it's all of those things, but it's not too familiar. It's not that sort of level of intimacy that a woman would have, of course, with her partner. And that can prove incredibly beneficial during labor and birth, particularly when things kind of go off the plan a little bit, or if there are complications or there are decisions to be made. Sometimes it's inevitable that emotions really run high in those situations, and that people allow their sort of emotions almost to cloud their judgment because of, you know, the anxiety, the fear, and the adrenaline, and all those things that naturally creep in. So doulas, being experienced birth support people, are knowledgeable. These things, you know, certainly with experience and attending more births will become less and less overwhelming for you too, and more familiar, and you are less likely to kind of get sucked into, again, that adrenaline sort of overload. And so you're able to provide that advice and support for a couple who might be feeling very overwhelmed, and again, help them to calm, help them to see things, you know, with better perspective, and allow them to make better, you know, informed decisions that are not fueled by emotion and anxiety. So lots of food for thought there, but, you know, I wanted to spend a little bit of time on this slide, obviously, because, you know, this is really the crux of our course, but really just to impress on you what an incredibly important role doulas play, and an incredible role you will be playing in the near future as you support clients both through Birth for Humankind and hopefully your own private clients as well. So we're going to talk about midwives now, and as you can see on the slide, it says that midwives are responsible for clinical care, gives intermittent support and comfort, present when possible in active labour, will support birth of the baby with a second midwife to support and assist. So just to, for those of you who aren't, you know, hugely familiar with the maternity care system here in Australia, and particularly here in Melbourne, about 70%, between 70 and 75% of women will birth in a public hospital in Victoria. So between sort of, you know, 25 to 30% are birthing in the private system, so private maternity hospitals. So when we're talking about the public system, generally speaking, midwives are the primary care provider. So during pregnancy, women will see a midwife in the antenatal clinic. Again, generally speaking, they will see different midwives at each appointment unless they are fortunate enough to be on an MGP, midwifery group practice, or team midwifery program, in which case they may see a small group of rotating midwives, or mainly the one midwife throughout, which is fantastic. But again, a very, very small percentage of women will actually be able to take advantage of that model of care. So midwives are who women are seeing antenatally. And then again, when they are in labor, you know, or if they present to hospital earlier for whatever reason, if they have any concerns, you know, it might be like a premature rupture of membranes, it may be bleeding, it could be they're not feeling the baby moving as frequently. So any you know, reason for them to present at hospital, they will be seeing midwives. Midwives are sometimes also nurses, but not always. So in Australia, it is possible to train both as a nurse midwife, so it's essentially a double degree, or there are also some courses, sadly not as many as there used to be, what we call direct entry midwifery. So these are people who really only want to be midwives and are interested in a nursing degree as well, and so they do purely a midwifery degree. So they will call direct entry midwives. So you're not necessarily going to know who's what, you know, either as a doula or if you're the birthing person. But essentially, if all is well and all is essentially normal, quote unquote normal, then midwives are really predominantly who women will be seeing throughout labor and birth. It is not unusual for a doctor to poke their head in and just check on things, you know, on their rounds. But really, unless there is a complication or a decision which really does involve an obstetric kind of overview, then it's entirely possible that a woman would really only see a midwife from beginning to end during the labor. And as the slide says, when it actually comes to the birth, so when a woman is really, really close to actually giving birth, then a second midwife in attendance will come into the room and will be there to support and assist the birth of the baby as well. So midwives really, as I said, they are there to provide all of that clinical care. They will do things like the fetal monitoring, the blood pressure, temperature checks, and so forth. They can administer medication, and there are a variety of procedures, interventions, and so forth that as well that they're qualified to do. If you can kind of keep at the back of your mind that midwives are the experts in normal birth, that's what they are trained to support. It's also, generally speaking, how they view pregnancy, labor and birth as well as a normal physiological event. And they're not treating it in a sort of a disease model or something that, you know, always has the potential to sort of get complicated or to go wrong. So that's not their mindset. That's not the philosophy and the approach of their training or their clinical practice as well. Things are quite different in the private system, and I think the easiest way to explain it is that if a woman is giving birth in a private maternity hospital, her primary care provider is her obstetrician, who, even if they're not there and present for a huge amount of the actual labor and birth, they do tend to sort of really arrive very close to the end of the birth. So the woman will still be cared for by midwives throughout the labor. The difference is, though, that in a private setting, the midwife is not generally making autonomous or independent decisions about caring for that woman. So if there is any decision to be made, everything goes through the woman's obstetrician, even if they are not physically on site or in the room at the time. They are on the phone, you know, and usually all updates are, you know, put through to the obstetrician. The midwife will, you know, will do that. There's also now, with the new technology, most obstetricians are able to quite carefully monitor what each of their patients you know, are doing and what's going on with the labor, particularly if they have continuous fetal monitoring or they have the CTG monitors on. There are apps on their phones where they can actually see the CTG trace without them even being on site at the hospital. So that's sort of a big difference between midwifery care within the public system and the private system, is that level of autonomy. Although, of course, even in the public system, midwives do not work independently, and certainly there is a hierarchy within the hospital system as well, and there is very much an obstetric, if you like, overhang that the midwives are having to work within and under in many cases. So there is more autonomy, but many midwives working in the system would strongly argue that they don't truly have autonomy, and they don't have truly that ability to make independent decisions because of, again, that obstetric overhang and that sort of very hierarchical approach in the hospital system, and many other things which really impact their ability to provide true woman-centered, person-centered care. You know, and we'll sort of explore more of that as well as we go through the course. So just to finish off exploring the various sort of team members, if you like, in the birth team, we'll have a look at doctors and obstetricians. So like midwives, they also provide clinical care for mother and baby. And again, depending on the model of care that the woman is utilizing during her pregnancy. So if she's going public, she may see an obstetrician for maybe one appointment during the whole pregnancy. She may not actually see one at all antenatally. She may only see midwives. However, if there is a pregnancy complication, and you know, such as It could be a maternal complication, so it could be something like the mum is advanced maternal age, gestational diabetes, a pre-existing condition, like hypertension. It could be a whole range of things, really, that kind of almost risk her out of being cared for purely by midwives antenatally. And so again, depending on the sort of clinic that she's been assigned to, it's quite possible that in fact she may not see really hardly any midwives in her pregnancy. She may only have doctor or obstetrician appointments in her pregnancy. One of the things I think as a doula that you can always do when you are meeting with clients and you're discussing their antenatal care, if you have a client who seems to be essentially seeing obstetricians almost exclusively during the pregnancy, it's worth suggesting to her that she inquire as to whether or not she could actually have some of her visits and appointments with midwives. The reason for that is if it's possible for that woman to kind of be out of the spotlight of a very obstetric kind of perspective for her pregnancy and subsequently for the birth, and she has more of a midwife input, there's probably a better chance that she will have a more low-tech birth as well. So it's always worth her asking if she can swap some of her appointments and be seen by midwives. Sometimes the reasons for seeing obstetricians is really, really flimsy, when in fact she absolutely could be seen and cared for predominantly by midwives, antenatally for sure. So that's something, that you could absolutely suggest that she inquire about. So the other difference obviously is if you have a client, this would be very less the case with Birth for Humankind, but very possibly with private clients in the future. You may have a client who is birthing in the private maternity system, therefore she has a private obstetrician, and therefore that's the primary care provider. Excuse me. They may have a midwife in their rooms that may perform some of the sort of the basic checks. But essentially, yes, if a woman is going through private obstetrician, he or she will be responsible for all of the decisions for relating to her care, both during the pregnancy and of course during the birth. There is a big difference during labor and birth in that private obstetricians, as I said, are not there for a huge amount of the labor, particularly if she's having a physiological labor, and will sort of tend to be checking in with the midwives, throughout the labor, and then sort of perhaps coming in from time to time just to check in and see how things are going. They may also do things like vaginal examinations and be, providing their clinical advice. And obviously, in most cases, will aim to be there for the actual birth of the baby. Very important to remember that doctors, obstetricians are specialists, and certainly they are highly trained and skilled when pregnancy and birth is complicated or genuinely high risk, and that is their area of expertise. And of course, certainly if a woman requires a cesarean section, it is an obstetrician who will perform that surgery. Likewise, in an instrumental birth, so if a woman needs support via a vacuum or forceps delivery, for example, that will be an obstetrician. That sort of is really outside the scope of practice for a midwife. So in an ideal world, midwives and doctors do work really closely together. They work well together, and each recognizes where one scope of practice ends and the other sort of begins, and so forth. It doesn't always work like that. It isn't always a perfect coexistence, and we do see quite different sort of dynamics at play, if you like, again, between public and private systems of maternity care. So hopefully that sort of gives you that kind of overview, as I said, of all the sort of people around supporting, the mum in the middle, who really always should be at the center of her care and the decisions about her body and her baby, but with obviously the support of a partner, ideally a doula, and her chosen primary care provider, be that a midwife or an obstetrician. We're going to move on to a new topic now, and we're going to start talking about how we build healthy boundaries, a healthy relationship with our clients, as well as with care providers. And it's, well, these things you might think, well, that's really obvious. And, of course, these are things that are important that we should do. And they are, but I think it's really important to point out the fact that sometimes those lines get blurred, particularly with your clients, which is only natural, especially considering how intimate and personal the relationship is or can be between a doula and their client. When you do work with somebody through, such a, important point in their life, such a transformational moment in their life, it's easy sometimes to sort of have those, as I said, those boundaries blur a little bit. Also specifically, I think when we talk about Birth for Humankind clients, some of these clients, have really experienced significant trauma in their lives. And, it is only a natural, I think, instinct and response to really want to protect some of them. I sort of hesitate to use the word rescue them, but I think sometimes we can find ourselves almost going down that path as well. So I'm going to read through some of these points on the slide, and as I read them, I'd like you to sort of have a think about them and what they mean to you. So the first one says, I am responsible to you, not for you. As a doula, you're there to walk with them through their journey, offering support as needed. You are not their savior. So that's very much that point I just raised. We are not there to save people. We're there to support them and be, by their side. But being responsible to somebody is really not the same as being responsible for them. There's a really big difference. The next point here, doulas are responsible to their clients in whatever way was agreed upon at the beginning of the relationship, but not responsible for them or their birth outcome. So we will talk in a future session about the antenatal appointments, what you would discuss, and very importantly, the topic of expectations, what your client's expectations are of you and vice versa. And so that's really clearly articulated prior to the birth. And then also, as this point raises, we're not responsible for ultimately how that birth unfolds. We cannot, just by being a doula and even though we know that having the presence of a doula really does improve outcomes, of course we can't predict everything, and we can't prevent a lot of things that happen. We can't prevent an emergency C-section or an instrumental birth or an episiotomy, or if somebody's had a prior C-section and they're hoping to have a vaginal birth, a VBAC, we can't guarantee that they'll have their VBAC, all of those sort of things. So again, it's about really, putting in place very clear expectations and responsibilities prior to the birth. Know the difference between what you have the power to change and what you do not. And again, I think sometimes we feel as doulas that, we want to fix everything. We want to prevent our clients from having, a difficult or traumatic birth or a poor outcome, or that we want to change the system, and things that frustrate us and upset us. But it's important to know, there are things we can impact and there are things that we can't. The next point, your emotional and physical needs are important too. If you need to eat, go to the toilet, take an important phone call from your family, you must prioritize these things. It does not make you a bad doula for recognizing that you need to care for yourself. And that's a really, really important point I want to emphasize. No one would expect anybody in any profession to work for 10, 12, 15 plus hours without a break, without eating, without going to the toilet, without checking in with your family, without having a few minutes just to sit and rest and have a cup of coffee. So very, very important. Often births are long and they are physically and they are mentally exhausting, and it's really, really important to look after yourself as well. Boundaries need to be made visible to others and communicated to them in the relationship. One of the best ways for a doula to communicate her boundaries with her clients is through a doula or a client contract. By explaining and understanding what is expected of both parties before the relationship unfolds, things are smoother and everyone is more satisfied. So again, we will talk more about contracts through the course, and also sort of towards the end when we talk about sort of the business of being a doula. And certainly I would strongly recommend for anybody who is anticipating that they will work as an independent, as a private doula with clients and take their own clients on, they absolutely have a client agreement, a contract of some kind that both parties sign that very, very clearly outlines what your services include and what they don't. There are lots of examples of client contracts out there, but again, we will get to that. In your capacity as a volunteer doula for Birth for Humankind, you are obviously protected by the organization's insurance policy and an overall contract of sort of client engagement. So that's not for something for you to individually worry about with clients that you take on through Birth for Humankind. And Kath and Christine will talk again much more about that, particularly at your induction training at the end of this course. Next point down, doulas must at all times act in a respectful manner when engaging with the client's midwifery and or medical team. Doulas must never come between a woman and her care provider when it comes to decisions regarding her care or her baby's care. The next sort of couple of things we're going to be doing today are a couple of activities which specifically look at the doula's scope of practice. So this is very much about the doula scope of practice, what we do, what we don't do, and as important as it is to develop healthy boundaries with clients, it is equally important to develop respectful relationships with care providers. And the reason for that is the final point on this slide. When doulas act professionally, respectfully, and within their scope of practice, the entire doula profession benefits as a result. The actions of one doula, literally just one doula, can also impact on the profession, creating divisiveness and ill will between medical staff and doulas. And just to give you a very quick little example, I was at a birth a few weeks ago with a client who was giving birth in a private hospital. And at some point during the labor, the midwife came up to me with a little piece of paper on a clipboard and asked me to sign a waiver. And I looked at it, and basically what it said was that I promise, I had to write my name, Tanya Cawthorne, doula, promise basically not to interfere in any way with the medical team, the midwives, the obstetrician, that I won't obstruct, that I won't be speaking for my client, etc. And I looked at the midwife and I sort of smiled, because we had got on really well, and I'd been there already for a while. And I said, oh, so I'm kind of guessing that maybe there has been a less than positive experience with a doula in the past, and that led to the hospital creating this document. And she just smiled at me and sort of nodded and said, mm-hmm. So that was the act of, possibly even just one person, one really negative experience that got, the whole hospital now has had to change, the way it works with doulas, and implemented a policy whereby all doulas have to sign this agreement. So it is really, really important that when we go there, we're acting, you know, not for us, just for ourselves and our client, but obviously as a Birth for Humankind doula, we are representing the organization. And when you are there with private clients, you're also representing the doula profession as a whole. And you know, every interaction that we have with clinicians and medical professionals is a really wonderful way and an important way for us to impact them in a positive way, and really to remind them of the important role that we play, and that we're not there to step on their toes, we're not there to replace them, we're not there to undermine them or their expertise in any way. We're there to enhance their work and of course to provide really wonderful support for the women. So have a think about them. I hope that's sort of a little bit of food for thought. As I said, we're going to move on to very specifically looking at the doula's scope of practice in the next couple of slides. Okay, so the first activity, and you'll find this in Better Impact, is getting you to sort of assess whether you think your action or advice that you might be giving to your client is either outside your scope of practice or within the doula's scope of practice. So here are some sort of general questions you can ask yourself if you're sort of thinking about, does this sort of sit within or without or outside that scope of practice? So are there claims of specific medicinal or healing benefits from the remedy as opposed to soothing a normal pregnancy or labor discomfort, or claims to correct or cure an abnormality? Okay. 2, are there any possible harmful side effects? 3, does the action or advice on this subject require special training, certification, or extra education to ensure safety and proper application? 4, does the remedy usually require a prescription or supervision of a trained clinician? 5, is the subject on which you are giving advice usually covered by a midwife or a doctor? 6, might your advice conflict with that of your client's clinical care provider? And 7, might your action or advice worsen the relationship between your client and her caregiver? So if the answers to all the above questions are no, then the action or advice is probably acceptable and within the doula scope of practice. But if the answer to one or more is yes, then you probably shouldn't do it. So the first activity that you'll see, there is a list of scenarios, and very simple, you just need to circle the yes box or no box. So yes, it is appropriate action to take as a doula, or no, it's inappropriate or outside the doula scope of practice. So you can pause this presentation and go off and do activity 1. Okay, so to finish off our section on today's topic of the doula scope of practice, we have a second activity, which you'll also find in Better Impact. You'll find a long list of sort of doula actions or advice. And what I need you to then do is basically separate out that list into three sections, 3 columns, if you like. So there are actions or advice which are appropriate and would very likely fall within the doula scope of practice, and they are sort of the pink cards. And then you have conditionally appropriate actions and advice, so they're yellow. And these actions or advice, they are within the doula scope of practice, provided that the client's care provider has been consulted and doesn't have any objection. Okay. The final sort of set of actions are green cards, and these are unacceptable actions or advice. So these are very clearly outside the doula's scope of practice. So that's what you need to divide up the big list and basically move them into one of those 3 piles. So have a go at that. We've got one more little sort of topic to finish up that sort of broadly comes under the doula scope of practice on the next slide. So this topic here does sort of loosely relate to the doula's scope of practice, but it sort of falls perhaps a little bit more under sort of the doula's ethical responsibilities, you know, for herself, but also very much for her client. Given the fact that, you know, most of us do spend a lot of time on social media, and there's no doubt that it can be a really great vehicle to build a business and to promote yourself as a doula. But here are just some things to be mindful of if you are considering using social media for your work. So if you have a look in the blue box, these are the sort of do things. So do understand your true reasons for wanting to share information on Facebook, Instagram, blogs, or other social media platforms. Do ask yourself how your clients, their families, their healthcare providers, and your colleagues will feel with the information you share. Do develop a few peers and mentors with whom you can share and confidentially debrief. Do remember that you cannot control what happens to the information and images after you publish it to the internet, even in the most confidential forums. So just because it's a private group doesn't mean somebody can't screenshot it and share it outside the group. I always sort of say, if you're going to put something on social media, it needs to be something that you really ultimately wouldn't mind being on the front page, you know, of the Age of the Herald Sun. It needs to be that public, okay? And do consider the consequences of friending clients. As a general rule, I would very, very strongly advise you not to friend clients, particularly on something like Facebook. In the orange column here, don't share stories that are not yours to tell. That's really, really important that we don't tell other people's birth stories, particularly. Don't be distracted during time with your client by texting, blogging, or updating social media. So don't do that, when you are attending a birth. Don't feel like you need to participate in social media outlets because others are doing it. So if it's really not the way you feel is the best way to present yourself in sort of the most authentic way, then perhaps there are other ways that you should look at engaging, with the community. Don't use public or semi-public forums and social media to share or discuss client information or seek resources not general in nature. And again, it's because social media is an extremely public environment, and it's very, very difficult to keep things confidential. And that's very much to my next point here. Don't break your client or colleague's confidentiality. It's a very small world, and even the smallest piece of information can be an identifier in the birth world or your client's community. So that's extremely important to be mindful of that. And don't post items outside of your private friend circle that cross the line between professional and personal behavior. Again, it's just really important to be mindful of the fact that, the sort of those lines between, it's my personal page can blur very much with your professional self as well. And again, depending on if you're representing an organization, if you are an employee at a certain place, in some cases, these are sort of, grounds for termination for some people in their workplace, and that certainly has happened to midwives in the past who've posted information. So, don't not use social media and the internet, because it can be a fantastic way to share information, to build a business, to share great resources with pregnant women and new parents. But just be very mindful of what it is you share, and think about what the motivation is behind what you're sharing. So our final topic for today's session is a little bit of an introduction to hormones. So the hormones of pregnancy, birth, and early postnatal. You're going to watch a video, which is a really, really great overview of the hormones, of pregnancy and birth. And the main hormones that will be covered are oxytocin, which in fact is, if you have a look at the image there on the left, that is the chemical diagram for oxytocin, also known as the love hormone. They will explore in the video also the stress hormones like noradrenaline, adrenaline, noradrenaline, and so forth, the fight or flight hormones. They will look at beta endorphins, sort of nature's natural opiate, and pain relieving hormones, and also prolactin, which is both known primarily as the hormone associated with milk production, but is also referred to as the parenting hormone, because it is a hormone that exists in both men and women's bodies, and certainly promotes sort of nurturing parenting behaviors as well, particularly in fathers. So it's a really interesting video clip. There's some really great people who are interviewed that are well worth sort of jotting their names down and perhaps Googling them, maybe following them on social media, signing up for newsletters and stuff. So just maybe as you're watching, just note down some of the names of the people who are interviewed in the clip about hormones. So just finally, to wrap up this week, just a very little bit of homework for next session, and that is to read, as you can see on the slide, pages 6 through 15 in your Preparing for Birth booklet, and that will give you a little bit of sort of a heads up for the topic that we'll be covering next week, which is to look at the stages and phases of labor and the sort of physiology of pregnancy, birth as well. So that's for next week. So make sure you get a chance to read that little section there in the Preparing for Birth booklet, as well as completing the activities from today's session as well. So I look forward to seeing you again next week.